one of the vortex vein ampullae may be dilated with the subsequent dilatation of the large choroidal vessels. So in CSC, acute CSC, what happens is the intervortex vein anastomosis, and there is a remodeling across the watershed zone. This causes a geographic delay of choriocapillaris filling in a geographic distribution, depending on how much of the choriocapillaris is occluded. And if it becomes a chronic CSC, chronic ischemia causes neovascularization and polyps at that site. So why we should know pachychoroid is because it is a spectrum ranging from pachychoroid pigment epitheliopathy. This is the normal orientation of the pachy vessels with the vortex vein, and here you have an asymmetric dilatation with this kind of crossing of the watershed zone and intervortex vein anastomosis, causing an occlusion of the choriocapillaris first in a geographic area, and later the geographic area is kind of obliterated. Chronic ischemia because of occlusion causes neovascularization at that site, either in the form of pachychoroid neovasculopathy and subsequently polypoidal choroidal vasculopathy. If this anastomosis is in the peripapillary area, it gives rise to the peripapillary pachychoroid syndrome. And if there are choroidal polyps that collapse, or if there is some choroidal scarring, especially prechoroidally, it causes a focal choroidal excavation. All these are included in pachychoroid spectrum. So it is important to know that the morphology of the pachychoroid or the choroid is more important than the metrics, because the measurement can be increased. Like it can be more than 350-400 microns depending on the machine that we use, but the pachychoroid can be focal, which gives rise to the pathology at that site. So like we can see here, there is an enlargement of the Haller's layers causing an attenuation of the choriocapillaris. Now let's look at focal choroidal excavation. So this is a case that we had of acute on chronic CSC, recurrent CSC attacks every year for this patient. And if we see the foveal line scan, there is what looks like a typical acute CSC. But this patient on autofluorescence showed an area of hyperautofluorescence in the superior macula, and the leak was also in that site. So basically this was a focal choroidal excavation in the superior macula. This can be conforming or non-conforming depending on the lining of the excavation with the retinal and the retinal layers rather. And the FCE is the nidus usually of all problems of pachychoroid, whether it's the source of leaks in CSC, whether it's the site of MNV, and whether it is polyps. So this is another case of a gentleman of 6'6" and N6 vision who came with difficulty in reading and a scotoma. So when we do wide field optos imaging, there is a yellowish lesion in the superiotemporal macula with a lot of subretinal fluid. The fovea was flat in the horizontal line scan. However, there was Shrem in the superiotemporal macula, and when we imaged further superiorly, there was this focal choroidal excavation that was causing all the problems. Now, he was treated with 2 injections, after which he was well for a while, but he came back with a recurrence, a solid recurrence with cystoid spaces at the macula, which suggested an MNV. You can see this MNV here possibly, and there was a component of CSC as well. You can see the neurosensory dip over here. So this is the area of the CSC leaks as well as the polyps that appear on the ICG at around the 4th minute. So why we should know FCE is because it's a potential site of recurrent leakage in recurrent CSC, MNV, PCV. It is a potential area of treatment, especially if it's extramacular, and it can be post-inflammation acquired FCE where neovascular complications may arise and need anti-VEGF treatment along with anti-inflammatory treatment. Choroidal cavern, what is known is that it was first described in geographic atrophy. These are angular, hyporeflective. They can be seen in bestrophinopathy and pachychoroid. So this is a cavern which is polygonal, completely hyporeflective inside. This is one of my cases. This was a case of pachychoroid neovasculopathy, and these correspond to areas of no flow on ICGA. This was the neovascular membrane on the OCTA, and this is the area of no flow when we do nocta through the cavern. So we should know about cavern to differentiate them from large choroidal vessels. Choroidal rifts are polygonal hyporeflective without hyperreflective margins, and the size is always more than the largest choroidal vessels. It develops perpendicular to the RPE and has filiform vertical processes. These are basically interruptions between the major vessels in the choroidal stroma. So there is a strain because of stretching, because of the fullness of the choroid or the congestion of the choroid, and these develop rifts in between the large choroidal vessels like we can see here. A choroidal loculation was described first by Spade. It is a loculation of fluid in the posterior choroid between the sclera and the posterior choroid, and it can even cause an elevation of the choroid, as was described by Manayat et al. So if we look at uveal effusion, it is a congestion of the choroid ciliary body, and the fluid freely pools in the suprachoroidal space because the attachments between the choroid and sclera are loose. But in CSC, the macular choroid is what is congested. There is only so much that the choroid can stand. So what happens when it is exceeded its capacity is that it goes further back and causes a loculation, and the angularity is directed towards the posterior choroid because of it is bound by the large choroidal vessels. So a rift, so why we should know rifts and loculation is because rifts represent areas of weakness between the large choroidal vessels and probably suggest chronicity, and loculation represents an overloaded choroidal stroma, I'm sorry for the typo, and that can no longer swell. And Spade has made this probable hypothesis that maybe we can make a shunt device at the macula which can drain out this posterior loculation. So choriocapillaris island is a CCI. It's a hyporeflective dark choroidal. It's a hyperreflective flow in the choriocapillaris in a background of hyporeflective dark area, and there is the flow area within no flow region is what an island is. It is because of a focal effacement of the choriocapillaris. I'm not sure if it is that or it is a reduced distance from the retina and hence captured in segmentation like so. And islands have been localized to leaks. A reduction in island size is seen post treatment or after regression of the fluid. We should know choriocapillaris islands because it is used as a non-invasive tool for detection of leakage points, and it can be a potential tool for guiding focal laser. Prechoroidal cleft, I think Dr. Mohit is going to speak more about this. It can be associated with all types of MNV. It can be associated with PCV as well. This is a choroidal cleft which is situated underneath a contractile fibrous tissue complex and multilayering of the RPE. So this is my patient.
Can you wind up?
Yes, ma'am. Just 10 seconds more. So this is my case of multilayered PED with prechoroidal cleft, who usually does not present with retinal fluid, but after injection, since he is one-eyed, the choroidal cleft changes. So intrachoroidal cavitation, this is a large cavitation in the peripapillary area. It can be associated with sinkholes, which can even be macular in location, depending, and there can be herniation of retinal tissue. So this is a leptochoroid where the peripheral, mid-peripheral choroid is very thin, and there is an area of hyperpigmentation at the macula corresponding to normal choroid. It is not necessarily in myopes. We should know leptochoroid because we have to differentiate it from entities like tilted disc syndrome. This is my case of leptochoroid but associated with dome-shaped maculopathy and tilted disc. So these are not just fancy acronyms. They are good reasons. There are good reasons why we need to learn about them. Helps in treatment and taking decisions of not treating, prognostication and knowledge sharing, and furthers understanding of disease process and